Thank you very much. First of all, thank you to the organizers of this great symposium. Thank you for the invitation. Okay.
We are a little bit too... I just heard, so we have, I think it's Katharina Fellgut who's ill, isn't it? So we will not have this talk, so we will be a little bit quicker. And we are, Titus and I, we have the challenge to really be in time and finish the symposium in time. And please, everybody stay until the end, because we have our traditional lottery drawing. We have a nice present for one of you. And now we have the slides, and Markus, the stage is yours.
I think it's not my slides yet. Oh, thank you. So thank you to the organizers. Thanks a lot for the invitation. These are my disclosures. Data-driven healthcare and personalized medicine have not just become the focus of many research initiatives worldwide. They have also become of interest to policymakers, and many hospitals are currently in a translation process from being data-aware to data-driven. And for this, I want to give you an example. If you're standing at a train station in the middle of nowhere and you're waiting for a train and you don't have a schedule available, then this is a situation where you could be aware that the schedule exists somewhere, but it's not shown to you. So once this information is presented, you are data informed, and if this drives you to an action, then this decision becomes data-driven. So where would we want to use something like this in the hospital setting? In heart team meetings for congenital heart disease, we ideally would require more information, in particular in borderline cases. We would need information on the outcome, on the short-term hemodynamic outcome after an intervention, and we would ideally want this information before the intervention is performed. And we also would like to understand better how these short-term hemodynamic outcomes translate into long-term outcomes for patients. In a recent systematic review we conducted in the German Center of Cardiovascular Research, we did not only find an increasing amount of publications coming out in the field of artificial intelligence, we also found that the majority of this data came from the patient's health record and from imaging data, followed by ECG and omics information. So the question would be, how could we bring such personalized approaches to the bedside in congenital heart disease? And patients typically enter the hospital, and a lot of data is being generated, and as you may know from your hospital information systems, this information is stored in cluttered, siloed architectures that are not always very well interconnected. Based upon this information that is typically manually exported for heart team meetings, for instance, decisions are being made, and this decision results in outcome that we can measure by conventional measures for outcomes such as survival, re-administration to the hospital, and re-intervention. But also newer outcome measures are becoming more and more popular, such as patient-reported outcome measures or development and growth outcomes. We are currently in the process, together with Katharina Schmidt's group, to digitally process the quality of life questionnaires for patients below the age of 18. And typically, if we acquire such outcome information, the patient repeats the cycle and comes to the hospital again. New decisions are made. So ideally, we have a longitudinal data architecture that records all this information and that allows, after some preparation processes, to run statistical operations on such data sets in order to also gain knowledge. So one example would be this cohort of patients with aortic coarctation. All of these patients underwent cardiac MRI in order to characterize the stiffness of the aorta using area distensibility in the ascending and descending aorta. And we typically find an overlap between different underlying factors such as the sensibility impairment, which was present in about 40% of these patients, bicuspid aortic valve disease that was found also in about 40%, and arterial hypertension that was seen in 70%. We also know there are influences of aging on these processes, and to understand this better, we used a non-parametric, non-linear model to actually find out what had the most impact or what correlated most. So in the ascending order, the impairment of this sensibility was most predominantly influenced by the presence of bicuspid aortic valve disease. For the descending order, there was a most predominant effect from arterial hypertension, and those patients that were hypertensive despite the use of antihypertensive treatment had actually the most impaired sensibility. On the other hand, across all ages, those with the normal blood pressure had the best sensibility across all ages. Another example for personalized modeling are biophysical models, such as this one, where based on 4D flow MRI data, we can make predictions about pressure gradients across a given stenosis without the need to perform invasive procedures. And one important point here was to also address the uncertainties of such methods, so to not only understand that these predictions are made possible, but also to see what the limits of agreement of such methods were. So those were within the range of also the agreement limits from what we expect from heart catheterization of about 6 millimeters of mercury. We also assessed imaging limitations, so minimal spatial resolutions, and came up with a concept of how to integrate such modeling procedures in clinical workflows. So when we now acquire such digital information from a patient, it also enables us to modify this digital information and to also create a situation of virtual treatment. So we can modify geometries, we can also modify inflow profiles or exchange valves in a patient in a virtual cohort and see what this makes to the simulation afterwards. In a small cohort, we did a validation study to see whether the predicted simulation of a surgical procedure followed also the postoperative state in these patients. And you can see that the flow profiles in the aorta match quite well. You can also see that in case number 5, it didn't match that well. So we saw more accelerated flow profiles in the ascending aorta, also showing that the boundary conditions and what we give into the model are of great importance here. So not all of our patients are under resting conditions as we see them during examination all day. So some experience symptoms during the day, and we also look into methods to modify these models according to stress simulations to see what the impact on the hemodynamics are, and also use an MRI step ergometer, for instance, to simulate stress in patients, use modeling methods, and we also can parameterize models better when using wearable devices to get a better understanding of how much time of the day patients spend in activity states. So this all was about statistical and biophysical modeling, where you have rules, you have data, and somehow the models come up with some answers, hopefully. So this is a completely different approach to what is considered narrow AI or machine learning, where you have data, you have answers, and rules can be conducted from it. To give you a completely medical example here, if you want to train a supervised machine learning algorithm to identify cats, you would need to identify features of a cat. You would also need to show a machine what cats look like, and also have a distinguished group of other animals such as dogs. And if you put this in the machine learning algorithm, then if the machine sees a previously unseen population, it will be capable of identifying cats and dogs. Can we use such labeling also for clinical cohorts? Of course, we can use clinical information to label this as input data. We can use outcome information to label it as an output of the model. And we can also integrate biophysical models here to augment information further. So in the last years, we developed an infrastructure that incorporates the data from the patient with the treatment decision and the outcome data to go in a longitudinal data architecture that then also assesses all the details that we need to label input and output information. And we came up by now with a data catalog that comprises of about 800 items by now from different categories that can be combined depending on study needs. So we use this in populations of aortic coarctation and aortic valve disease. And we are also in the process, together with our colleagues from congenital heart surgery, to use this in the congenital aortic root database where we have about 15 centers to join. Is it okay to just once in a while check if data quality is okay? Probably not. We should do it more frequently and probably on a very regular basis, and ideally have infrastructures that also have mechanisms established to detect data that is out of range, but also detect data that seems to be completely false. This is an example looking at the coarctation arm of the database. We see 455 features here on the x-axis, and we see 350 patients grouped here on the y-axis, and with an average follow-up time of 3 years. And we need to pre-process such information in order to make reasonable predictions here. So we need primary data cleaning where duplicates and unnecessary data needs to be properly fixed. Then there's one step of data splitting, which is quite important, because if we would use all this data, we would simply have a non-usable model, or we would not have any possibility to verify the information from the modeling process. So we split this up in a training cohort and in a test cohort. Then we need to select which features to include. If we only have 350 patients, we, with more than 400 features, would have way too many input features here. So this needs to be broken down to the essential features here. We need to remove multicollinearity from the data set. We need to remove zero variance labels, and we need to adapt this more to the needs that are for the model to perform best. So then pre-processing of data depends a little bit on the method that you're going to use. If this was for a neural network, then this could be other techniques than for boosting algorithm, for instance. And finally, the actual machine learning algorithm takes place, where, for instance, in a neural network, the labeled input features are somehow connected to the output features, with a lot happening in between. I don't want to go into all the details here, but there are modifications for the number of neurons, the number of layers in such models that can be further fine-tuned. And this fine-tuning, model re-evaluation, is actually a step that really takes some time. It takes computational power. It also takes iterative approaches to be repeated. In the end, the model needs to be evaluated. So we can have a look here at the training cohort, performing quite good with an accuracy of 93% of accurate predictions. So we only have very few false positive and false negative patients here in the prediction. But the question would be, how does it perform in the test cohort? So how does it perform in data that was previously not seen by the model? And we can see here that it performed not as good as in the training cohort, but still identifying 79% of the data correctly, with a sensitivity and a specificity of above 80%. Now, is this all black box magic where we put data in and get data out? There are many approaches to perform explainable AI interpretations, such as this one. If we look at a high-risk patient here with a probability for reintervention of 80%, then we can detect which of the input features had contributed most to this decision. And we see here that in this case, we had the time after the initial intervention that had very high impact. We also had factors contributing to patient age and weight that had a high impact, but we also see that we have the blood pressure of the upper and lower extremities, which the machine algorithm detected. So the machine algorithm basically detected what is in the guidelines for identifying patients that are at risk and that require heart catheterization. We can also predict the time of reintervention. So the prediction was 23.5 months. The actual time for reintervention here was 21 months. We're also applying this to the cohort of ROS patients we have, with actually a follow-up reaching back to 25 years at the German Heart Center. But this is a little bit more complicated, as there is a large variety in time spans of how much follow-up data is available. So we have an average follow-up of 5 years, where we have also sensitivity and specificity depending on the machine learning algorithm used of around 70 to 80%. But this needs to be further fine-tuned also for those that had longer outcome times. So if this information continuously update once a patient comes to the hospital, the model can easily make a new prediction, and we could ideally have such reports also coming out from models that can tell us a little bit about risks according to the previously trained networks. It is also possible to have, once new information comes in, to have this information contribute to an added learning process where all this new data goes into the fine-tuning of the model again and re-alterates the model. And in the end, there needs to be human interaction, a human in the loop that interprets the model, looks for reasonable answers, and also seeks if this is of any help when it comes to providing the right treatment to the right patient at the right time. So, to sum this up, trustworthy AI requires high-quality data sets. We need labeled data, data infrastructure that actually collects outcome data. We need also translational study designs in order for such studies to be conducted. And once such models are clinically validated, they can help to individually simulate outcome information, assess risks, assess timing of events, probability for timing of events, and can also, once modified, help to provide in silico treatment options. So modifications can be made possible here. Thank you very much.
Markus, thank you very much for this huge overview. So is there any question from the audience? Oh, yes, please.
Tremendous. Thank you very much. So this is a trend to go to a very personalized view on the patient, which is something what is really true and what should be helpful for them itself. But on the other hand, we need some guidelines. What is the way to translate these personalized findings back to the guidelines that we have an averaged optimization of our treatment for the patients?
It's a very good question. I think the guidelines approach is a completely different one than to personalize treatment in a patient. So if the guidelines rather come up with a one-size-fits-all approach in personalized medicine, this is not the case. We can still use the data and data analytical processes to learn things, to increase the amount of evidence available that could also influence guidelines. But for an individual case, a patient would probably not be very satisfied with the answer of reintervention of 50%, because it would either be 100% or not. So I think to incorporate such personalized approaches into guidelines would require also a different thinking for such guidelines to be composed. If there are randomized controlled trials showing that such methods can be of additional benefit to a patient, then a suggested modeling procedure could be something to include in guidelines. This would be the way I would see it. Okay.
Thank you very much, Markus.